Hello, this is Val Worthington, and I am uh, looking forward to having the latest in a series of conversations I'm getting to have with friends and colleagues in the Jiu-Jitsu community. This is part of a bigger effort called Grappling with Answers. If you like what you hear here, then please find us on YouTube and subscribe, and also find us on Facebook and like us. And also feel free to share with your friends. Today, I get to talk to David Parkinson and Whitny Castaño, who are healthcare professionals who have some interesting perspective on the quarantine, on the pandemic, and I'm so happy to have the chance to talk to them. So thanks to both of you for being here. The first question that I have for you is to say a little bit about your jiu-jitsu backgrounds, and I'll let you decide who gets to go first.
Ladies first.
All right, Val, thanks for having us on. My name is Whitny Castaño. I've been training jiu-jitsu for about 12 years now. I'm a brown belt out of, I guess it's considered a Hanzo school. I train under Jonathan Webb and Bruce Quinn. And I've just competed on and off for the past few years while going through school and finally finishing. David?
Sure. Hey, Val, thanks for having us. I'm a jiu-jitsu brown belt. Got mine in Philadelphia at Balance Studios under Phil and Rick Migleris. Sort of freelancing these days, but training for about 12 years.
And I'm guessing, and we can go into this in some more detail, but I'm guessing that your jiu-jitsu habits have changed in the recent past. And that's a good segue into my next question for you, which is if you could say a bit about your educational and professional backgrounds, and then what you're doing currently in terms of roles and responsibilities.
Again? Okay. So I have a master's degree in nursing, as well as obviously a bachelor's degree in nursing and a bachelor's degree in law. I went to college while getting into jiu-jitsu, and I went from being a bedside nurse and an oncology unit, transitioned to a telemetry floor, eventually to ICU step down, and now I am a nurse practitioner between a couple different facilities, specializing in subacute rehab, long-term care, and assisted living.
How about you, Dave?
For me, I like to mention this because I feel like it's almost formal education, but I was in the Marines for 5 years. I'm a combat veteran. Then went to school at Temple University and got my BS in kinesiology. After that, went to Drexel University, got my BSN, and started working for one of the larger hospitals in Philadelphia, where I did bedside nursing, have experience in oncology, step down level, critical care type, med surge, and then moved to Denver actually 3 years ago this month. And work at one of the larger hospital systems here. Stepped away from the bedside recently, and now have a different role, which I can go into really quickly if you have time. So my title officially is care manager, and what that looks like in the hospital, it's sort of a buddy program with social work. Our focus is to look at the totality of that patient's hospitalization, and our focus is getting patients out of the hospital, in and out, as quickly as possible and as safely as possible. Oftentimes when a patient comes in sick, you're looking at what made them sick, how do we fix it? There's a whole story that goes along with that patient, how they got into the hospital, how the hospitalization's going, how the family's affected, and then what it looks like for them to go home. Do they have a home? Do they have insurance? What sort of care will they need after to not come back into the hospital, which helps also the hospital systems cut down on readmission rates, which is, pretty large fine. And so my goal is to look at every case, large scale, get them out as quickly as possible. And again, kind of get to know them when the doctors don't have time to. I deal with every discipline in the hospital, therapists, nurses, doctors, speech, everyone who's involved in that case. So I'm very visible to the patient. I do still go to the bedside. We have conversations, talk to families at home. Most of my work takes place behind the scenes, but it's still hands-on patient care as far as that goes.
So David, why don't you continue with the next question? We'll switch the order because a lot of the things that you're describing, as I'm thinking about that in the context of the pandemic, I'm wondering what's changing for you. What's different? What kinds of things have you seen that that are unprecedented or that are new?
Sure. Speaking to that, obviously, no matter what, it's important to remember that COVID might be on the tip of everyone's tongue these days, but there's still a lot of other disease processes that bring people in. Nothing's changed there. And I think what we have to face is people coming in who are uninsured, and that happens all the time, and how to best benefit them. People coming in who are taking care of family members that are already disabled, getting sick. Just looking at the overall structure of the hospital system. For the last, 100 years or so, this is unprecedented, obviously. It's been the same sort of set diseases, and that's how we allocate our floors. That's how we allocate our nursing staff and our doctors. Well, this is a new virus that we're still trying to negotiate through, and therefore you have to make certain accommodations in the hospital. They're moving ICUs, they're moving entire staffs to different wings of the hospital to help quarantine individuals caring for COVID patients, both at the ICU level and the medicine level, if you will, stable. There's been nurses who started out and were hired as surgical nurses who are now medicine nurses, having to do direct care with COVID patients only. Everyone had to adjust as far as staffing goes. We've had to adjust. I currently operate as the ICU care manager for COVID ICUs, which is challenging, and it's difficult to negotiate when to talk to families because they're not allowed to visit these patients in the hospital. They're relying on conversations from doctors daily, and possibly myself to give them updates without speaking too much information to stay within the scope. So I think the infrastructure of the hospital system is forever changed because of this. Will continue to grow and change. And my role is going to continue to grow and change. And I'm sure you can speak to her recent transition from the bedside and now prescribing and working in the rehab facilities, because that's been tricky.
Yeah, Whitney, I see you nodding, and I'm wondering what this raises in your mind in terms of what you're experiencing.
Well, before I left the hospital, they already had started transitioning different wings of the hospital to be specific COVID wings to help try and protect the patients that are higher risk of developing the virus. So they would try and be on one separate section of the hospital to help prevent them from getting sick while being treated for a congestive heart failure exacerbation. And then after leaving the hospital and going into the rehab, they're just doing something very similar where they have the subacute rehab wing. The one hallway is specifically for COVID patients. And then they have all of our protective equipment down that hallway, and they try and keep the same nurses in that area so as not to spread the virus to other people that are also very high risk. But because so many healthcare workers are also becoming sick during this time, and they are ending up pulling some of the COVID nurses and COVID aides to the different wings of the hospital. So it's just, we have to be very mindful of what we're doing and how cleanly we are being when taking care of these patients, so we don't take it to a different wing, like the dementia unit or the long-term care facility, or in my case, my one wing on the second floor is all non-English speaking patients. So it's very difficult to interact with them and try and find out what's going on with them and treat them because everybody's presenting very differently. But everybody has to just restructure and kind of go with the flow, because what is normal one day is not going to be the same guidelines the next day. So everything changes very quickly.
And you have to sort of turn on a dime, it sounds like.
Mm-hmm.
When you mention rehab, am I understanding correctly that you're talking about rehab from COVID? So if someone has had COVID and then they're being rehabbed in terms of healing from that or getting over it?
Some of them are COVID patients. Some of them are just patients that went in for surgery and then came to the facility for physical therapy and stuff like that. But anybody that's coming into the facility that hasn't been COVID tested automatically goes onto the isolation wing, but they're going to be in a different area than the confirmed positive cases, because we keep them on a type of isolation for at least 14 days before we let them go and interact with any of the other patients that have been there for a long period of time. So some of them are, as I said, like tibial fractures, and some of them are patients that are rehabbing from being intubated from COVID.
So along those lines, a lot of the discussions that people are having, particularly, so I don't have COVID, I'm trying to prevent it, right? So that's where my focus is. But there are some people who have been tested positive or who are being treated, and that's something that the both of you see on a regular basis. You see what the treatment is, you see what what the patients are going through, and I'm wondering what you think it's important for people like me to know about what you're seeing when it comes to treating people who've tested positive. David, you want to go first?
Sure. Well, there's a lot of talks online about staying out of the hospital if you're sick and you have symptoms. And I think that's a good guideline to follow. Washing hands, keeping social distance, 6 feet, wearing a mask. I mean, a mask can prevent, honestly, a lot. If this is spreading through droplet, which is a sneeze, a cough, saliva, things of that nature, touch, wash your hands, obviously, then wearing a mask helps a lot. When people do come into the emergency room, it's usually because they've had shortness of breath, and that shortness of breath worsens. And it's to the level where, say you have an asthmatic who comes in regularly to receive treatment for breathing issues. These people that I think a good guideline would be, if you're having shortness of breath and you're not an asthmatic, and you're having fever, which is another CDC sort of symptom, then you should go into the hospital. Outside of that, if you have manageable symptoms, you should stay home and self-quarantine. When people do come in, depending on what hospital you work at, out here in Colorado, at my hospital, we have rapid testing in the emergency room. And just because you have symptoms does not mean that you will be tested for the COVID virus. If the doctors feel that you have enough indications to be tested, they will test you. And I gotta say, that is very uncomfortable test. I believe, Whitney, you have a test coming up on Monday, is that correct?
I do.
So it's a very uncomfortable test, and it's a viral test. So we're able to detect if the virus is active in your system. That still doesn't mean you'll be admitted to the hospital. They may send you home and quarantine in place, depending on what your social situation is at home. If you have the ability to do that, or how intense your symptoms were at the time. So the people that have been admitted to the ICUs are people that are generally highlighted as high risk. They come in with shortness of breath, they have fever, they have multiple comorbidities like diabetes, you name it, any sort of cancer, anyone who's got immunosuppressed or respiratory issues, who may possibly get to the level where they're needing ventilation. In that case, I think the doctors have done a really good job, doctors and nurses, of identifying those patients and getting them to the proper units. I think we've also done a really good job of sending people home appropriately who may be tested positive as well. We are trying to maintain the assets we have right now with tests and negotiate who should be admitted and who should not be admitted. Obviously, as you can imagine, if you're working down in the ED daily, PPE, protecting yourself, people coming in, you have no idea what could possibly be wrong with them. Everyone's utilizing PPE. A majority of our PPE is going down to these EDs and these COVID units. We're reusing a lot of things. We're recycling these materials. We are not wasting gowns. We are not wasting masks. These people need it the most because of high exposure. So that's sort of the screening process going in. I would say in the ICU, what happens is a person who, if that virus triggers a response in their body that possibly affects the lungs hard, it's a multi-organ system virus. If that person, oxygen requirements increase, it happens very quickly. When it happens quickly, we do, positioning like supine and proning, ventilation early, Those people will be in events sometimes for 20, 30 days until their lungs recover. I have noticed in the ICU that people trend, they get sick, they plateau, and then they sometimes rapidly improve as far as respiratory organs, the labs look better, things like that. There are also people that get sick, plateau, and then tank again. And it's really how fit is their body to be able to combat attacks it just took being ventilated, fighting the virus off, with affecting multiple organs. Very hard to track. Right now, the approach is, and I talk to a lot of doctors about this, the approach is to do the least harm possible to the organ systems that the virus may be affecting, while trying to maintain that patient's breathing and ability to fight infection. Because, Whitney can speak to this, being on a ventilator for just a couple of days can make your body physically weak to the point where it's difficult to lift your arms, your legs, move. You might have came in there as a triathlete, and in a couple of days being ventilated with paralytics, medications that we're throwing at you, heavy IV dosing antibiotics, you may struggle to lift your arm above you. That's where these rehab facilities come into play. So we're seeing a wide spectrum. The people that go directly to the medicine floor are identified as high risk, but they don't have as vicious symptoms as someone who would need an ICU level of care. They're staying in the hospital week and a half, and discharging home once we get through those symptoms. So I've seen the sickest person have absolutely no comorbidities, and somebody who had a ton of comorbidities be on 2 liters of oxygen and just kind of bopping around on those units. So wide range.
Yeah. So it sounds like one of the things that I took from what you just said, David, is that one of the things that we can do for ourselves is to try to keep ourselves as healthy as possible. And Whitney, I'm wondering if you can speak to this question of what you think people need to know about what you're seeing on a day-to-day basis. And in your response, could you also talk a little bit about what the test entails, the test for COVID?
The test that I'm very much so looking forward to on Tuesday is going to involve sticking a very long Q-tip basically up my nose, and I believe it kind of goes down partially into the back of my throat. A lot of people bleed while doing this, but now the new standard, where in the state that I live, requires all people that work in rehab facilities and subacute care facilities to have this test completed by the 26th. And if you don't have it completed, then you are not allowed to work in the building until you get it done, basically. But if I come back positive, even though I'm asymptomatic, I'm not going to be allowed to work in the building for 10 days from when the test was done. They do also have other tests that they can do. They have the saliva-based test, which some people are going to do if they have like deviated septums and stuff like that, and it's difficult for them to have the test done. They also do have a blood-based test, which is actually looking for antibodies, but that's more for people that have already had confirmed positive, so they're trying to get plasma to help treat other people that are acutely ill. In terms of how we're treating it in the facility, because we are very much so finding patients coming up positive in the facility when they weren't positive in the first place. There is no real exact way that we're finding people presenting the same. Everybody is presenting a little bit different. The one common theme we are seeing between everybody is they're just not feeling right, but how they're telling you is a little bit different depending on their age, their other comorbidities, whether or not they have dementia. And then all of a sudden they'll get this unexplained fever. In a rehab facility, we don't have the same capability of getting blood work done as quickly as you would in a hospital. So generally, if I order blood work at 8 o'clock in the morning, I'm not going to have it until 8, 9 o'clock at night, or even sometimes the next day. If they're not even that sick, say that my patient says to me, something just doesn't feel right, or I had a low-grade fever of 99.1. And generally, people don't consider that a fever at all. But now we're treating it as a fever and getting immediate blood work and chest x-rays. And most of the time, they're not coming up with anything out of the ordinary. And then, but within 24 hours, they'll have a fever of 100.3. but because it's a virus, there's no real treatment for a virus. We are treating the symptoms that are going along with it. So if their chest x-ray shows that they have a pneumonia, then I'll start giving them IV antibiotics to treat the pneumonia. Hydration, we're finding, is a big important thing with them. So I'm recommending that all my friends drink fluids, and that doesn't mean tea or just even like Gatorade or anything like that. I'm saying you need to drink water. That does not mean iced tea. That does not mean coffee. I mean, you should drink water on top of your whatever else you're drinking too. They're also finding that vitamins are playing a big role in helping combat the virus. So vitamin C, eating oranges, taking supplements like that, going out in the sun, getting your vitamin D. We're giving all of our patients that are starting to present with any kind of symptom these additional supplements, just because from what we've treated so far in the facility, we're seeing a better turnaround when they're taking supplements on top of the antibiotics for whichever organ system is being affected. But because we're also in a facility and we don't want to increase the rehospitalizations like Dave was talking about before, we're holding on to these patients a little bit longer to try and treat them so they don't have to go back in the facility. Because what if they don't really have COVID? They might just have pneumonia, or they might just be having a heart failure exacerbation. So we're not automatically throwing them back into the hospital just in case it's something else. And actually, a lot of times we're not even getting confirmed positives, but we're thinking to ourselves, based on their presentation, they're actually going to be positive if they were tested.
So first of all, I have to interject a fun fact. I know I'm not supposed to touch my face and my nose is itching. Like I can't, it's sort of like, don't think about the elephant, think about anything but an elephant. So now my nose is itching, but I know that I shouldn't be touching it. So little levity there, but I'm listening to you talk. It sounds like basically you're both just working in the middle of a giant science experiment here, where you are on the fly testing what works. You've both mentioned that from your perspective, the way we practice medicine, or the way the professionals practice medicine, is going to change, is going to be changed forever. One element of that I think is on a lot of people's minds, particularly people who have lost their jobs and may, as a result, have lost their health insurance, is the influence of health insurance and the interaction of that with people's decisions about how they're going to take care of themselves. Can you talk a little bit about what you've seen along those lines in terms of in terms of how it would affect, someone who may think they're sick but doesn't know if they'll have the care available to them?
I can go. Sure. I deal a lot with insurance, and we get I want to say this as a caveat. Thankfully, the weather is getting warm. There are a lot of people out there that do not have homes and shelter, and so that will, in essence, down on the amount of people that come into the hospital, for the sandwich or the bed for the. There are a couple things out there. Oftentimes when people come to the hospital and they say are undocumented citizens, or make a low enough income to qualify for Medicaid, which is a state-based insurance, and we'll start that process. The process has not sped up any. It takes about 30 to 45 days to process an application from when you start it. So that doesn't really help a lot of people, especially if you're sick acutely, to do that, especially for COVID patients who come in who are uninsured or underinsured, if you will. From my understanding, and this is state by state, your insurance benefits from your work, if you had a job previously and had insurance, should continue to support you for an additional 4 months. That is, you have to file for unemployment. And there is the CARES Act that was passed in March, which basically said that if you file for unemployment, you'll be covered for up to 4 months and can, in addition, sign up for what's called the PUEC, or Pandemic Unemployed Emergency Compensation, which increases your benefits for an additional 13 weeks while you're not working. And I think the stipend's somewhere around, and it's state to state, but around $600 per week of coverage as needed. I'm sorry, per month, not week. So people who are fearful that they don't have their employee-based benefits, they should still have them from the time that they file unemployment. For others, it's difficult. If you're very sick and you need to come into the hospital, come into the hospital. The hospital will not kick you out. The hospital will treat you, and they'll treat you as long as they need to discharge you in a safe fashion as to not put the public at risk, but also protect that person. We're not turning people away by any means. So if you do suffer from the sort of CDC symptoms, shortness of breath, cough, fever, sore throat, loss of taste and smell, all these things, some GI things, you can come into the hospital, and we will, in my department, financial counselors and stuff that work in the hospitals, work on getting you what's called an emergency certification for Medicaid, which will pay for your hospitalization during this time. We do that even in non-COVID times for people who don't have the means to sign up for insurance. But we've been doing that pretty regularly in the hospital. And I don't want to go off, veer off, but one thing that's been very important too is establishing medical power of attorneys and medical proxies when people come in. More so than ever, because oftentimes these patients get very sick, they're intubated right away, or they're confused. They can't answer these questions for themselves. So establishing that, state has different laws. For instance, in Colorado, we have a very open system of establishing who is considered an interested party. So hopefully you get in touch with that spouse, that brother, sister, et cetera, et cetera. But in the case that doesn't exist, Fred from the bus stop could be an interested party and walk in that patient's room and be now your medical proxy for the day. So I don't want people to panic and worry. The hospitals are open. We're doing everything we can to free as many beds as we possibly can. My job is to, again, still continue to get people out quickly and safely. That means if you can get medical care at home that you don't need to stay in the hospital for, I set that up for you. We have been getting a ton of charity, sums of money to help people get home safely. Social work also provides in my department means for homeless shelters, respite beds, a number of things to keep people safe and out of the hospital so they're not also further exposed, because that, going to the hospital seems like a good idea when you're sick. However, there's a ton of people in there with the virus. So we try to limit the amount of people we admit while treating what we have and getting the ones out we can as safe as possible.
Thanks, David. Whitney, what are you seeing along those lines?
I don't deal with the insurance nearly as much as Dave does, but when I do have friends that have questions about what they should do, I do tell them that if they are at the point where they feel like they need to go to a hospital, absolutely go to a hospital. But there's a lot of things they can do at home to relieve the symptoms, to kind of stay at home rather than go into the hospital and possibly get infected if they're not already infected with COVID already. So there are wonderful people with these great jobs that are there to help you get this insurance. So just because you don't have insurance, that shouldn't be a reason to not go to the hospital if you are having difficulty breathing or it feels like your heart's racing.
Thank you for that. It's got to be such a tough call to make when you are in that situation. So I appreciate the clarification there. Another thing that seems relevant is that I imagine that you're seeing sometimes that people who come in with symptoms have people at home who they're providing care for. So if you have someone who, for instance, is recovering from a heart attack, Whitney, or someone that you've seen, Dave, who needs care at home and their caretaker contracts the virus, that's got to have implications. And so there's this domino effect that happens. So can you speak to that a little bit?
You want me to go?
I'll go first. So a lot of times we're finding that some of my patients are ready to leave rehab and go home, but then we're having trouble reaching the caregivers. And then we'll find out a day or two later that the person's actually in the hospital. So we end up holding on to these patients longer than expected until other plans can be put in place for home care and for something a little bit more permanent. So somebody's readily available to take care of them back at their house. So it's just preventing us from sending my patients home when they should, if their caregiver is suddenly sick and in the hospital. But also a lot of times if my patients come in from my facility and the caregiver is afraid that they might bring COVID home to them, we are having to keep the patients longer than necessary because we have to test them to kind of give peace of mind to the caregiver at home that they won't themselves get sick from me sending the patient back to the house. That's what I've seen so far.
How about you, Dave?
Well, I'm rubbing my face too. In the court of common sense, one would think that if somebody came into the hospital sick with COVID virus and was tested positive, that the people at home probably also are positive. So that said, about 20% of Americans are deemed disabled in this country prior to COVID. That could be, psychological, but, physical. These are people that rely on their family members or friends, or, hired home care workers to take care of them daily, bathe, eat, all these things. Without those things in place, those people have to come into the hospital. So, and to use a couple of examples, we've had multiple family members on the same floor come in with the virus that contracted, sort of critical symptoms, and we're treating them, simultaneously. We've had husband and wife, one get admitted to one hospital, one get admitted to the other hospital, both elderly. They're ventilated, things of that nature. A lot of interesting social situations when one makes it and one doesn't, which has happened as well. And then you have those people that we refer to as frequent flyers that come in to the hospital because they have a lot of medical necessities, a lot of physical necessities that maybe aren't rehabable, but they fall into what we know as long-term care, or what most people would refer to as a nursing home. We call it long-term care. These are people that can't fend for themselves anymore. And in a lot of cases, these people are safe at these long-term care facilities. However, could we have done a better job of being a little more proactive at the beginning and limiting visitors to these facilities? Perhaps. Some of these older populations were exposed. They get the virus. They may be in private rooms, almost self-quarantining, but they're eating in common areas. If you've ever been to a nursing home, they're getting therapy walking around the units. They're exposing other people. So when it comes to discharge, it's absolutely very difficult. The patient may have came from said facility, but now the facility doesn't want them back until they test negative for the virus. They're closing down some facilities to quarantine the people that are in place there. So that limits the ability to discharge people safely. And if you think about a complex case for someone who has a lot of necessity for caregiving at home, they can't discharge from the hospital either until we have a safe situation to discharge them to. And end up back in the hospital, or in worse, who knows, in a worse scenario. Everyone who's admitted with the virus, kind of have to wrap your brain around everything surrounding that person's social situation and medical situation, because they possibly have affected a number of other people. A lot of the families we see coming in who are multiple members are infected. They're living in small quarters. There's often a lot of people in those apartments or small townhomes, and there's a high risk of exposure all the time. So it's been very difficult to treat this virus and treat these patients. It's been very difficult to discharge these patients because we go off CDC guidelines. World Health Organization, what we should be doing, and then dealing with private companies that provide aftercare for these patients, and them trying to negotiate how can we make money, how can we best serve the community of our patients, and what would be the safest course of action. We've had multiple rehabs shut down or close with the patients inside. Obviously, we still have workers in there until further notice. Just like, they close gyms and all these things. So that said, the importance of getting people home to a safe situation is still as high as it's ever been, but it's become a lot more difficult. So.
Do you want to add to that, Whitney?
I definitely agree with there's a certain level of fear about these caretakers when they are admitted to the hospital. They're afraid to go home because they're afraid to infect the person that they're taking care of. So they may end up not going home per se, but going to stay with somebody else. And it makes it more difficult to take care of their loved one. And they have to have other family members step up to the plate if possible, family, friends, or they'll have to have healthcare workers try and negotiate home healthcare aides that can come in for a longer period of times to help care for their loved ones that can't care for themselves at that time.
You're raising a really important point here, which is I think one of the things that happens when you're overwhelmed with information, like I feel like we are, it's easy for someone who isn't seeing what you're seeing every day to forget that each case of COVID is a person who has a complex life, who has people who love them, who has social situations, and is a living, breathing person and not just a statistic. And so I really appreciate. I'm sitting here sort of starting to feel even a fraction of the weight that I'm imagining you must feel when you're interacting with these people. They're not just cases; they're people. And so I wanted to acknowledge that and say that I appreciate that. I'm starting to appreciate even a tiny bit of what you must experience every time you talk to somebody who is caring for a loved one or has the virus themselves. So kudos. You had mentioned, Dave, the idea of people going back to normal life or going to their gyms and as one example, and one of the things that we as jiu-jitsu people care about is when we can go back to training safely. And I was wondering if the two of you would speak to that as well, as people who train yourselves and like to train, and also as health professionals who know what the implications are of maybe going back too soon.
Sure. Well, I just want to say, and this is something that we talked about offline, is that we're going to be okay. I think we're going to get through this fine. I just don't think we're there yet. And I think that is, the scientific method at its finest, trying to figure out how to best prevent the spread of this virus, come up with quality vaccines, and hopefully eventually maybe come up with a pathway to sort of treat this. We're not there yet, and we're working through each case. So that said, when it comes to training, I think we could all agree that grappling might be one of the most intimate of sporting and martial arts that you can get involved in. I don't think jiu-jitsu, if it were to come back now, which it's possible to, will be the jiu-jitsu that we were used to, at least for the immediate future, until we can come up with those methods to kind of combat what we're dealing with now. You want me to go into suggestions for Jim?
Sure. And then, so why don't you go into suggestions, and then Whitney will hear from you too.
I think that gyms can open. I think that certain things need to be in place, if possible, to be healthy and responsible with your population that they're going to also have possibly infecting. One thing you mentioned earlier, I just want to backtrack is, feeling a little bit more real. These people, they're not subjects. There's one side of the coin in science where it's looking at case by case bringing the data together, started coming up with ways to best go about things. At the end of the day, it's still people. You're putting not only yourself at risk, but you're putting others at risk, and I think that's important to remember when you're out there in society. So if you forget your mask at home, go back and get your mask. If you don't wash your hands after going to the grocery store or before, take a couple extra seconds and wash your hands before and after, because you don't know what you could be carrying. So that said, I think gyms can do it intelligently. I think sparring for now needs to be added, because I don't think, again, we're there yet with the science. But we do know that washing hands works. So maybe drilling. There's a lot to jiu-jitsu other than sparring. I think you can set up individual drill stations with good coaching, keeping social distance, setting up sanitation systems within the gym, possibly even recruiting, a willing or hiring a willing healthcare provider for your gyms, to do, light screens and pay attention to the people and keep the peace sort of between these stations for now, if possible. And just, cleanliness, washing hands before, washing hands after, hands, face, arms, whatever you can. I also think it's important to possibly limit the amount of students in the gym, possibly by doing signups online and then being approved to come in. Waiver signing again, a little bit different waiver than you're used to signing for jiu-jitsu to participate. But maybe this time, am I symptom free? Have I had fevers in 72 hours? Things of that nature. And going off of the guidelines the government has presented to us in your local state and federal government. And maybe introducing it to the world that way. I think that would be the safest method if we have to go back now. I'm sure everyone's chomping at the bit too. I am struggling with my personal hobbies currently, but that would be the adjustment I'd make if I were a gym owner.
Thanks, Dave. What do you think, Whitney?
I agree with Dave in that jiu-jitsu, as we know it, love it, and have sweated through it, is a very intimate, up close and personal thing. So jiu-jitsu, as we know it so far, is not going to be the same for a little while, because we are going to be sweating in each other's eyes. I think that gym owners should set up screening systems, kind of like whenever I go into my facility, I have to have my temperature taken. I have to answer certain questions like, have I had any fevers? Have I taken anything to lower my fevers so that it's no longer considered over 100.1? So that way, when I had my temperature taken, am I really sick, or am I just taking Tylenol? So right now I don't have a temperature. I agree with Dave that maybe they should employ some kind of healthcare professional to even just like look at somebody's throat, see if it's red, listen to their lungs. Have they been coughing? Do they sound congested? I think that everybody should have some type of physical before they're able to return to jiu-jitsu. I also agree that there should be limited classes. For the time being, it's probably going to be a lot of solo drilling. If people that live together, I'm sure they're already still training together. I know I am training in my basement with somebody that I live with. So if you are living together, you're more comfortable and more likely to practice moves together, maybe even have live training sessions together. Gym owners should also, I personally think they should not only make the classes smaller so they can spread out and have the online signups, they should make them a little bit shorter so that way they have the opportunity to disinfect the mats and the people have the opportunity to disinfect their equipment and themselves before going home. Because just because you're training doesn't mean that everybody that you're living at home with isn't exposed to what you're bringing home too. So one of the good points I was talking to about with one of my gym owner friends is that he's living at home with an immunocompromised wife. She takes medications because she has Crohn's disease. So just because he's healthy and safe doesn't mean he's not putting her at risk. So jiu-jitsu as we know it is going to come back, but it's probably not going to come back as soon as people would like it to. And unfortunately, people are going to have to be patient because it's not just you, it's everybody you're living with that is going to be exposed to it also.
Yeah, Thank you for that. I know that like you said, everybody's chomping at the bit, but it's comforting to know that that in the future it could look similar to the way it's looked in the past. But like you say, we have to be patient. So thanks for that insight too. What have we, in sort of the grand scheme of everything we've talked about, what have we not covered that you think it's important to talk about or that you would like to share? And Whitney, why don't you go first?
I just kind of want to touch on one of the rumors that I've experienced. People have been saying that hospitals are making more money off of labeling deaths in patients as being COVID positive, and that's why we're coming up with so many positive cases now. And I just want to say that that's very much so not the truth. Hospitals are actually losing money because people aren't coming in the same way they were. They're not doing all these elective surgeries, and it's actually getting to the point where people are being laid off. I know a lot of emergency room doctors. Somebody that's been a physician in an emergency room for 27 years is being laid off because they don't have the capability of keeping them employed right now. I know their entire scribes, the people that write the notes for the doctors when they dictate them, have been laid off. Physician assistants. A lot of people are losing their jobs because hospitals aren't making the money that they think that the general population is assuming they're making by labeling the patient as COVID positive. And Dave can talk about this part himself, but nurses are being asked to come on for longer periods of time for incentive programs, but then there's still the fear that they might not be making the same amount that they were promised, or they're losing 10% of their pay because the hospital or the facility isn't able to, they don't have the money there anymore. And I think that's important to know that this isn't just a gimmick, this isn't a hoax, this is very much a real thing that's affecting not even the general population, but healthcare workers themselves.
And is not a money-making venture for hospitals. Right. Thank you for that. Dave, you want to follow up?
Sure. Yeah, just at the place I work now, it's one of the larger hospitals in the region. That's multi-state. And make no mistake, a hospital is a business for sure. So I'm not going to dispute that. However, when we stop surgery, which is the moneymaker in a hospital, to prepare for the rush of patients coming in with COVID virus, the hospital, I'm sure, has lost millions of dollars, which has led to what Whitney's talking about. People have had to do jobs that they have no experience in as bedside nurses. There are doctors operating outside of their scope of practice, trying to figure out, pull together as many resources as possible to combat this. So that gives me a lot of hope that everyone has been very proactive and selfless in this situation to help come up with a solution as quickly as possible. But, you know, to go back on something we talked about earlier, familiar with the term FTE? So essentially, yeah, it's essentially like a full-time sort of position that the hospital accounts for to fill. This is a new virus, and although it looks like I have the flu, I have fever, maybe chills, maybe shortness of breath, things like that, it doesn't act like the flu at all. It's a completely unique thing, which means that we have not prepared in the hospital system for this FTE. We don't have a specific COVID expert, and the nurses aren't trained on this. So the infrastructure, like I talked about, and the way we have to go about things, and who we decide to cut, and who we decide to keep, and who we decide to send home, as far as staff, is always changing. I could tell you we are not making the money that we used to make at all. I would say maybe at least 50% cutbacks since this has started. So I would say that I'm very thankful to have a job in this dynamic right now. And I'm not sure what that's going to look like down the road. But there are no hoaxes when it comes to us, the hospital people trying to make more money, because that's not the case. We're just trying to do what's safe and effective for each patient, trying to clear up space in these hospitals, bring in as many as we possibly can, when the country continues to open up more and more people are exposed. And, you know, I think, I don't know, I take it day to day. I'm the cleanest I've ever been in my life. I wash my hands probably 20 times per day. My hands are raw. You know, I try to wear a mask everywhere I go. You know, so far so good. And I think that we just have to really be patient. We have to really take into account that it's not just us, that we protect each and everyone in our life. And if you care for people and the people in your life, then, you know, I think we all need to kind of look inside and do the right thing right now. All I do is lift weights these days because that's all I have. But, you know, that has filled the need. That has filled that for jiu-jitsu or hobbies. And we're all going through this together. Healthcare workers, people at work, people working in service, lawyers, accountants, everything. So just something to keep in mind, be safe, and, you know, show a little more appreciation to your common, I guess.
I like it. I like it. And one last question for you both, and you touched on this a little bit, Dave, is what are you doing to stay grounded and positive, particularly given the nature of your jobs? Whitney, do you want to start?
Sure. I have been working out a lot. I wake up, I run, go to work, come home, and luckily I have my boyfriend that's in the basement right now lifting weights because I'm on this phone call. So I have him to lift weights with, to push each other a little bit further, to still do jujitsu and some pad work with. And then we're just cooking, trying new recipes, just trying something new. And now that the parks are opening back up, we'll start going on hikes again. Just get back outside, get off your phone, and stop reading everything online.
Yes. Dave, how about you in beautiful Denver?
Well, it's sunny, so that's good. I have that to look forward to most days. There are still hiking trails open, maybe not some of the more prominent, heavily trafficked ones, but there's plenty to do out here as far as getting outside. The other day I went for a bike ride, you know, to FedEx. I ran to the storage unit, pulled all my weights out of storage months ago. I set myself up at home gym. I kind of utilize that every day. I'll go for jogs in the park. You know, cook elaborate dinners, get into some great Netflix, you know, whatever I can to distract myself. But you know, I found that honestly being quarantined really helps you get in pretty good shape. So I would suggest doing that. And it's also a great tool to stay healthy. I definitely take vitamins, Whitney, so thanks for dropping that. Drink tons of water and just try to be as healthy and as fit as I can daily. So that way, if I do get sick, my body is ready to fight off whatever is thrown at.
And I think that's a really important message coming from two healthcare professionals, that for those of us who are wondering if we're doing enough, if we are doing the right things, that really this sort of addressing this virus starts at home, right? In terms of taking care of yourself and the people around you. So I think that's a great place to end. Whitny Castaño, David Parkinson, thank you so much for talking with me. I really appreciate it. And maybe offline we can talk about some of the lifts you're doing so that I can learn from and do some of them too. So thank you very much. I appreciate it.
Thanks for having us.